Hi there, welcome to this video. In today's Learning Bite, we'll be going over first-generation antipsychotics, also known as typical antipsychotics, drugs which are commonly used in the treatment of schizophrenia, other psychoses, and mania. So what are we going to be covering today? We'll be talking about some examples of different drugs that fit into this drug class. We'll be talking about their mechanism of action, their side effects, how they're monitored according to the BNF guidelines, and also going through a single best answer question. On the screen now are some examples of first-generation antipsychotics that you might come across in your clinical practice, in the wards, or in GP surgeries. These can include drugs like chlorpromazine, haloperidol, flupentixol, pimozide, and sulfuride. So what's the mechanism of action of these drugs? The way they work relates to the dopamine hypothesis of schizophrenia. This theorizes that an imbalance of dopamine neurotransmission causes the symptoms that we find within clinical practice. So the principle of first-generation antipsychotic mechanism of action is that by reducing the neurotransmission of dopamine, we then reduce those symptoms of schizophrenia. Therefore, these drugs have their effects by being D2 receptor antagonists. The target area of effect is the mesolimbic pathway, which is associated with the positive symptoms of schizophrenia. This involves things like hallucinations, delusions, abnormal movements, and thought disorders. However, this D2 receptor antagonism is non-selective, meaning that these first-generation antipsychotic drugs also affect other dopamine pathways and other dopamine receptors in the brain, causing some of their side effects. One of the most common types of side effects that occur with first-generation antipsychotics are known as extrapyramidal side effects, and these occur because of inhibition of the nigrostriatal pathway. EPSEs include things like Parkinsonism, where you get bradykinesia, which means slow movements and a tremor, and this is more pronounced and more common in elderly females. You also get dystonia, which means uncontrolled muscle movements, and you find that more commonly in young men. Two other symptoms that also constitute EPSEs are akathisia, which is that feeling of inner restlessness, and tardive dyskinesia, where you get these involuntary movements of the face, the jaw, the tongue, etc. Other side effects of first-generation antipsychotic drugs include hyperprolactinemia. Normally, dopamine inhibits prolactin release from the pituitary gland, but with dopamine receptor antagonism, you lose that inhibition of prolactin, and therefore the amount of prolactin you have increases. This leads to side effects like galactorrhea, which is an abnormal milky white discharge from the breasts, gynecomastia, which is abnormal development of breast tissue, and sexual dysfunction. Other side effects include prolongation of the QT interval, which is most commonly associated with pimozide and haloperidol. Some patients have a risk of postural hypotension, which means that you might be more wary about them having a fall. You can help to limit this risk by titrating the dose. However, in contrast to second-generation antipsychotics, first-generation antipsychotics have a lower risk of metabolic side effects. This includes things like weight gain, the propensity to develop type 2 diabetes, and the propensity to develop things like dyslipidemias. However, one of the things you need to be wary of is something called neuroleptic malignant syndrome. Neuroleptic malignant syndrome is a life-threatening neurological emergency which can be precipitated by antipsychotic drugs. Patients can get symptoms like hypothermia, fever, sweat, reduced GCS, muscle stiffness, autonomic dysfunction, and a blood pressure that goes up and down. So that's known as a labile BP. So that's something to be wary of if you're in an emergency medicine placement and a patient comes in with those symptoms with a past history of schizophrenia who has been taking some antipsychotic drugs. Because of the risks of these drugs, the BNF requires that there's some monitoring done for patients who are taking antipsychotics. The information on the slide is something that I've adapted from the BNF guidelines. So you can see at baseline, you need to monitor the weight, the fasting blood glucose, HbA1c, blood lipid concentrations, ECG, blood pressure, and then your full blood count, USANEs and LFTs. At 6 weeks, you just measure the weight. And at 12 weeks, you measure the weight, fasting blood glucose, HbA1c, blood lipid concentrations, and blood pressure again. At the 1-year interval and every subsequent year after that, you monitor the weight, fasting blood glucose, HbA1c, blood lipid concentrations, blood pressure, full blood count, USENEs, and LFTs. This helps to check for any cardiovascular and metabolic side effects. Finally, we're just going to finish off with a single best answer question, something that might come up in your end of year papers. So in this case, there's a 24-year-old man who's been prescribed chlorpromazine, which is a first-generation antipsychotic, after being diagnosed with schizophrenia. A few months down the line, he talks to his GP, complaining of a low sex drive, and he's got gynecomastia. So which pathway is implicated in the development of these side effects? This question is testing the relationship between the anatomy and physiology and the side effects of these drugs and the clinical implications of how it presents. So the correct answer here is option number 5, the tuberoinfundibular pathway, and we'll go through why in just a moment. It's not the mesolimbic pathway, because that's associated with the positive symptoms of schizophrenia. It's not the mesocortical pathway, because that's associated with the negative symptoms of schizophrenia. It's not the nigrostriatal pathway, because that's associated with EPSEs, so there's extrapyramidal side effects and the Parkinsonism that you might find. It's not the corticospinal tract, because that's associated with motor movement. And it is the tuberoinfundibular pathway. This is because there's less dopaminergic inhibition of prolactin production, meaning that you get more prolactin, therefore you get hyperprolactinemia. As a result, you get these symptoms of a low sex drive, gynecomastia, etc., etc. That's all for this video. Thank you very much for listening. If you have any feedback, please leave a comment or send a message. Thanks a lot.